Immunology Insights, Basics and Beyond, Chapter 62, Immunotherapy for Autoimmune Diseases. Marcello here. Welcome back to Immunology Insights, Basics and Beyond. In our previous chapter, we met Georges Köhler with his hybridoma technique and saw how monoclonal antibodies turned immunology into a precision toolkit, laying the groundwork for many of the therapies we now use against cancer and immune-mediated disease. Today, we stay in the world of therapy, but we change perspective. Instead of talking about boosting immunity against tumors, we will look at conditions where the immune system is too active or misdirected, autoimmune diseases. And we will explore how modern immunotherapy tries to re-educate rather than simply suppress the immune system. So let's talk science. What do we mean by immunotherapy in autoimmunity? Autoimmune diseases arise when the immune system mistakes self-tissues for foreign and mounts a sustained attack driven by autoreactive T and B cells, autoantibodies, and inflammatory cytokines. Examples include rheumatoid arthritis or RA, multiple sclerosis or MS, systemic lupus erythematosus or SLE, type 1 diabetes or T1D, and inflammatory bowel disease or IBD, and many more. Immunotherapy in this context means targeted modulation of immune pathways to reduce this self-directed damage while preserving as much normal host defense as possible. Instead of broadly shutting down immunity, the goal is to dial down disease-driving cells or molecules, spare protective responses against pathogens, and ideally restore a more tolerant, balanced immune state. In practice, that spectrum ranges from classical broad immunosuppressants to highly targeted biologics and more recently cellular therapy. Let's start with the more conventional backbone, the broad immunosuppression. For decades, treatment of autoimmune disease was dominated by non-specific immunosuppression. We had glucocorticoids like prednisone that rapidly reduce inflammation by blocking multiple pathways, cytokine production, T cell activation, and adhesion molecule expression. Then we had conventional DMARDs or disease-modifying antirheumatic drugs such as methotrexate, azathioprine, mycophenolate, and cyclophosphamide that interfere with lymphocyte proliferation or function. These agents remain the backbone in many diseases: RA, lupus nephritis, vasculitis, severe myositis, because they are broadly effective and relatively affordable. Their downside is obvious. Because they are not specific for autoreactive cells, they also weaken normal immune responses, increasing infection risk and causing long-term toxicity, for example osteoporosis, metabolic changes, and organ damage. This is where targeted immunotherapies come in, aiming to keep the benefits but reduce the collateral damage. Now let's look at the targeted therapies with biologics, so precision immunosuppression. Therapies with biologics are usually monoclonal antibodies or fusion proteins designed to target specific cells, cytokines, or pathways. They are not perfectly specific for autoreactive clones, but they tend to hit pathways that are disproportionately used by pathogenic immune cells in a given disease. There are two important concepts. First, they often target activated or memory cells, for example CD20 plus B cells, more than the naive cells, so autoreactive populations are preferentially affected. Second, they are given at controlled doses and intervals, allowing partial immune reconstitution and vaccination strategies to reduce infection risks intermittently. Let's walk through 5 major mechanistic classes with concrete disease examples then. First, we have B cell targeting, so autoantibodies and beyond. B cells are central in many autoimmune diseases, not only as producers of autoantibodies, for example anti-CCP in rheumatoid arthritis, anti-double-strand DNA in lupus, but also as antigen-presenting cells and cytokine producers. Key strategies involve A. CD20 depletion, rituximab, ocrelizumab, ofatumumab, target CD20 on pre-B and mature B cells, but not on plasma cells. Indications include rheumatoid arthritis, ANCA-associated vasculitis, some cases of systemic lupus erythematosus, and relapsing forms of multiple sclerosis. They work despite not being autoantibody specific because autoreactive B cells are part of the CD20 plus pool and are often more activated. Depleting this compartment can reset B cells' repertoires. Plasma cells survive, but over time their numbers and autoantibody titers often fall. B, we have the BAFF-APRIL pathway blockade. Belimumab, so anti-BAFF, reduces survival signals for B cells and is used in SLE and also lupus nephritis. This preferentially affects autoreactive B cells that rely on chronic BAFF exposure. These therapies are usually long-term but can induce sustained remission and steroid sparing in many patients. Second, we have the T-cell co-stimulation blockade, so turning down the T-cell help. T-cells require not just antigen recognition via the T-cell receptor, but also co-stimulatory signals. Without proper co-stimulation, they become anergic or regulatory rather than fully activated. Here we have abatacept, which is a CTLA-4 Ig fusion protein that binds CD80, CD86 on antigen-presenting cells, preventing them from engaging CD28 on T cells. This dampens T cell activation and results in less help B cells. Clinical examples include rheumatoid arthritis, juvenile idiopathic arthritis, and some forms of psoriatic arthritis. Because abatacept blocks a step in activation rather than killing cells outright, it tends to have a somewhat more favorable safety profile, though infection risk is still increased compared with the general population. Third, we have the cytokine blockade, so intercepting the inflammatory conversation. Autoimmune diseases can often be mapped onto particular cytokine signatures. Blocking these signaling molecules can profoundly alter disease activity. Important access and examples include A. TNF or tumor necrosis factor. Here drugs like infliximab, adalimumab, etanercept, and golimumab are used, especially in indications like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis or axial spondyloarthritis, and inflammatory bowel disease like Crohn's ulcerative colitis. They reduce joint damage, skin lesions, and gut inflammation by interrupting a central inflammatory amplifier. B, we have the IL-6 pathway, where drugs like tocilizumab, sarilumab, which is an IL-6 receptor blockers, are used in rheumatoid arthritis, giant cell arteritis, and some difficult inflammatory syndromes. IL-6 is hereby a key in acute phase responses, driving CRP elevation, anemia of chronic disease, and systemic symptoms. C, we have the IL-17, IL-23 axis, where drugs like secukinumab, which is an anti-IL-17A antibody, ixekizumab, and ustekinumab, which targets IL-12, IL-23, and guselkumab, which targets IL-23, target the Th17-driven pathway central to diseases like psoriasis, psoriatic arthritis, and certain spondyloarthropathies. And D, we have the IL-1 blockade, where for example anakinra or canakinumab are used in autoinflammatory conditions, for example CAPS, systemic juvenile idiopathic arthritis, and some recurrent fever syndromes. Although these agents do not know which cytokine molecules are autoimmune versus infection related, they are chosen where a given pathway is chronically overactive, and clinicians mitigate infection risk through screening, for example tuberculosis or TB, vaccination, and careful monitoring. Fourth, we have trafficking and adhesion, so controlling where the cells can go. Another strategy is to keep immune cells away from target tissues. A would be here integrin blockade. Natalizumab, which is an anti-alpha-4 integrin, blocks lymphocyte entry into the CNS and is used in relapsing multiple sclerosis. Or vedolizumab, which is an anti-alpha-4 beta-7 integrin, is gut selective and used in inflammatory bowel disease, limiting T-cell homing to the intestine. B, we have S1P receptor modulators like fingolimod, siponimod, or oxanimod, who trap lymphocytes and lymph nodes by modulating sphingosine 1-phosphate receptors. They are widely used in multiple sclerosis to reduce relapses by preventing autoreactive T and B cells from entering the CNS. These approaches do not fix autoimmunity at its roots, but by changing cell trafficking, they substantially reduce tissue damage in target organs. And fifth, we have the complement and other pathways that can be targeted to block the final effector phase. The complement system is an important driver of tissue injury in some autoimmune diseases. For example, eculizumab and ravulizumab block complement component C5, preventing formation of the membrane attack complex. Indications here include paroxysmal nocturnal hemoglobinuria or PNH, atypical hemolytic uremic syndrome, and generalized myasthenia gravis with anti-AChR antibodies. In these diseases, complement is a major effector of the cell lysis or neuromuscular junction damage. Blocking C5 can dramatically reduce hemolysis or muscle weakness, but it also increases susceptibility to encapsulated bacteria, especially meningococci, so vaccination and prophylaxis become crucial. Relatively new and emerging, but very real, are cellular immunotherapies in autoimmunity. Although most approved immunotherapies for autoimmunity are antibodies or small molecules, cell-based approaches are beginning to enter the picture. First, we have CD19 CAR T cells, which have induced deep, drug-free remission in small numbers of patients with refractory SLE, myasthenia gravis, and other B-cell-driven autoimmune diseases in early trials. By eliminating nearly all CD19 positive B cells, including the autoreactive clones of course, they can reset the B cell compartment. Long-term safety and durability are still under investigation. Second, we have regulatory T cell or Treg therapies, which aim to boost immune tolerance by expanding or infusing Tregs, with early studies in type 1 diabetes, graft versus host disease, and other conditions. And third, we have hematopoietic stem cell transplantation or HSCT, which, also not new, remains a powerful but high-risk option to reboot the immune system in severe MS, systemic sclerosis, and some other diseases. These approaches are still limited to specialized centers and highly selected patients, but they illustrate that the line between cancer-style immunotherapy and autoimmune therapy is starting to blur. However, can we actually achieve long-term remission? For many autoimmune diseases, our current therapies control rather than cure. A subset of patients, for example, with RA, IBD, and psoriasis, can achieve drug-free remission, especially with early aggressive treatment. In others, long-term therapy is needed to keep disease quiet, and treatment may be adjusted over time. Curative strategies such as gene therapy, correcting specific monogenic immune defects, or HSCT to reset the immune repertoire exist, but are restricted to particular conditions and carry significant risks. The emerging challenge is to induce durable tolerance, turning off pathogenic responses while keeping protective immunity intact. That remains a central research goal. Now let's look at the clinical relevance, so balancing benefits and risks. Immunotherapy for autoimmune diseases has reduced reliance on chronic high-dose steroids, transformed outcomes in diseases like RA, MS, IBD, psoriasis, and SLE, and improved quality of life and functional status for millions of patients. But it comes with trade-offs. There's increased risk of serious infections, for example tuberculosis or TB, and other opportunistic infections. There is a constant need for vaccination planning, cancer screening, and monitoring. And of course, there are high costs and unequal global access. For clinicians and patients, the art lies in choosing the right mechanism for the right disease at the right time and revisiting that decision as biology and life circumstances change. To conclude, immunotherapy for autoimmune diseases shows that the immune system is not just a weapon to be unleashed. It is a complex network that can be retuned. By selectively targeting B cells, T cell activation, cytokines, trafficking, and complement, we can transform many autoimmune disorders from relentlessly progressive conditions into manageable, often well-controlled diseases. We are still some distance from true immune cures in most cases, but every new biologic, small molecule, and cell therapy offers another step towards safer, more durable control and ultimately restored tolerance. In our next chapter, we will stay with the theme of immune modulation, but change the enemy again, this time to pathogens, exploring immunotherapy for infectious diseases, and how some of these same tools can help us fight chronic viral and bacterial infections. Before closing, I have a small request. If you enjoyed this content and want to hear more, please like and subscribe. It's a small step for you, but it helps me a lot. So thank you for listening and see you next time.